Okay, good morning, everyone. My name is Eric Marsh. I'm a pediatric neurologist at the Children's Hospital of Philadelphia, so welcome to Philadelphia. We're going to shift a little bit we have all the COE directors here, and we're going to have some clinical discussions about clinical care and what we've learned from all being involved in the study and seeing a lot of kids with COE. And let Judy introduce herself next.
Yes, hi, I'm Judy Weisenberg. I'm the director of the St. Louis CDKL5 COE, and that's me. Yeah, so the idea behind this, we don't have a lot of slides. The idea behind this was really to have a shared discussion about a bunch of very big topics within clinical management, a little bit about research. I've been thinking a little bit about the term expert because it's been used a lot this morning, and it's an interesting term, but every single person in this room is an expert because you are all, those of you who are parents, are experts in your child, and you know way more about a lot of medical and scientific topics than a lot of other people. But so really this is about sharing experience and hopefully having some open discussion.
Yeah, and so we have some slides which are just meant to really be a starting point for you guys to ask questions. And the panel sort of knows what we're doing here, but we're going to also ask them to give say a few words first about themselves, and then go on to talk a little bit about, for each of the slides we put up, say some comments about how they treat some of these issues. But then we really want people to get up and ask us questions. Just to state, we're not going to answer specifically about anyone's kid at this panel, but we'll give more general comments about ways to treat things. Introductions. All right, so Heather, let's go down the...
Hi, I'm Heather Olson from Boston Children's Hospital. I've run our Center of Excellence since 2013 or 2014, I believe. Quite a while now, so I've gotten to meet a lot of families and learned so much from you. So I think I've learned as much, way more than from you than any textbook or any article I could read, and I appreciate all of that. So we have a multidisciplinary program that's always a little bit in flux, and we're going to be doing some more evolutions over time. Happy to answer specific questions about that.
Hi, I'm Dana Price. I am at NYU, and I run our CDKL5 Center of Excellence there since 2019. And I also want to say thank you to all of you for all of your dedication and support over the years.
Elia Pestana Knight, and I have been taking care of children who have and families who are affected by CDKL5 since 2014. And again, I want to share a voice what my colleagues have said. What we know today is because of all of you have come to us, has trusted us to take care of your children and also learn about this disease, which today is not that rare among the rares. But I want to mention one more thing. What you're saying here is true. We work together, but the girls, we go for breakfast together, and they go to the bar. So it's not by chance that...
Everyone was invited to the bar.
Good morning, everyone. Rajaraman. I'm a pediatric neurologist. I did my fellowship in epilepsy. I'm the director of the UCLA CDKL5 Center of Excellence in Los Angeles at UCLA. See about 20 to 30 families with CDD. It's been a true pleasure taking care of families with CDD and working with everybody here on this panel. It's a real highlight and treat of my career. Thank you.
Hi, my name's Tim Benke. I am a pediatric neurologist. I'm at the University of Colorado, Children's Hospital, Colorado. We have had our Center of Excellence within our Rett multidisciplinary clinic since 2011, and it's been a pleasure to get to know all of you.
Scott Demarest, ditto to everything he said, and I help with the epilepsy side of things and whatever else Tim asked me to do. And it wasn't a bar or breakfast thing. We're just, the guys are a little bit slower in general, and so it took us a while to get to the stage, that's all.
Hi, I'm Bernard Zuder, and I had the Center of Excellence in Texas, and which is incorporated into the Rett Multidisciplinary Center of Excellence, and have a special interest in epilepsy and movement, and I'm really enthused to meet all of you.
And Bernard, keep that on. Why don't everyone just go back and say what is at your clinic, like what services each of you, the clinic provides?
All of them.
a little more details, doctor.
No, so the multidisciplinary effort is really a great one where multiple providers circle around the families in a given day of clinical assessments. We obviously have the pediatric neurologist, we have a physical medicine provider, we have pulmonary medicine in there, we have GI, very importantly. My colleague, partner in crime, is over there here at the conference and will speak later, and cardiology, and just a whole complex of providers that may be useful to your children's care.
So we have a multidisciplinary clinic at Colorado. It's jointly funded by Rocky Mountain Red Association and IFCR, kind of reflecting the population that we see. When people come, they see all of the specialists that they need. You know, the Colorado experience is such that, you know, people are coming from the plains, they feed the cows at 3 o'clock in the morning, jump in the truck and drive to see us. The idea is that when you get there, you want to see everybody that you need to see in an afternoon or a morning. And so the new patients see 13 different providers from pediatric neurology, GI, dietitian, rehab, physical therapist, speech therapist, occupational therapist, cardiologist, pulmonologist, developmental pediatrician, and social work. And so we shove all of that into the morning. The only way that we're able to do that is we have a nurse coordinator, also known as a cat herder. Tristan, are you here? So that's how it works. We wouldn't be able to put all these services together if we didn't have the support that we have from you guys to do this. It's not necessarily something for all of us that our hospitals are eager to jump into because they just wonder why. And we try to explain to them why, but you are the reason why. You've put it out there, and that's why we're able to do it. Anything else you need to say? Right.
So we have something similar at UCLA with traffic at LA. 5 minutes of what should take 5 minutes takes like an hour, right? So we try to get all our providers together quarterly. So we do our CDKL5 clinic quarterly, and then I see our patients, or they see their providers at separate times. So we're always available, but we try to do a quarterly multidisciplinary clinic where the family stays in one room and we kind of rotate through. I think nursing and social work is probably two of the most important people that don't get highlighted enough because they don't charge or get reimbursed or anything, but we help support them, and they really kind of help the families as much as possible. So we have GI and genetics and everything else, but nursing and social work is super helpful.
Hi. So I have a model that is different from what you have heard already, and this is for many reasons and structural reasons. So up to here, we have been talking about centers that are located in children's hospital. Our center is located in an epilepsy center. So we function different from everybody else, and also we cover a large area or number of states within the northeast part of the country, where there is a lot of snow and mobility becomes an issue. So my patients are from Michigan, Indiana, West Virginia, Pennsylvania, and Ohio. So what we did in 2015, we tried to initiate our program with that model that you have heard, and we find out it was extremely difficult, number one, to get the patients there when we were able to get all the providers together, and number two, get all the providers together because they all have different departments and different bosses that made this very difficult to coordinate. So we changed our model to the patient is in 3 or 4 times a year and as needed, and we coordinate with the local providers so they can get a lot of the services that they need. Because you might imagine if you have problems with GI and you're coming from Indiana, it's very difficult to get to the Cleveland Clinic. So we know a lot of people, we know a lot of parents, we know a lot of physicians from many different places and different hospitals, and I think that is a model that so far have been working, but if it's not, here are my parents to tell me otherwise.
So just following off what Elliot was saying, partnering with the local neurologist, I think it's super important because, you know, families come to see the COE or they're not even able to come, but let's say we see you only once a year, but having a partnership with the local neurologist One, for the families in case they have emergencies or anything. They have somebody to rely and support them. It's difficult to prescribe medications across state lines if you don't have a license in that state. And just having a neurologist locally that we always talk to makes things easier. So just having that kind of open communication.
Yeah, that's a very good point. Getting licensed across all the states is a problem that I have every year because I have to maintain license in 5 states. Yes.
So, like Elia, in New York, space is at a premium, and we cannot have a clinic with everyone together. As much as it sounds amazing, we've tried since I started and are unable to coordinate because of our different bosses and insurance reasons. So for that reason, patients come to see me in the epilepsy center where we have a ketogenic dietitian who they can also see. And then at our various locations around this, they see my colleagues, the GI doctor, the pulmonologist, the geneticist, developmental pediatrics, social work, our rehab center with our OT and speech therapists and physical therapists. Unfortunately, it's not all together, but we do make sure that they are getting all of these appointments and seeing all of our colleagues.
We have like a theme here. So in Boston, similarly, our program has been a little bit more broken up. So we have a genetic counseling assistant who helps talk to families and prioritize with myself and my team what visits are most important to each individual family. I follow a mixture of local, semi-local families for whom I am the primary neurologist. There are some families even within my center who have a different neurologist as their primary, and then they see me maybe once a year for making sure we're up to speed with CDKL5 specific recommendations and any research opportunities. And then I follow families from around the US and internationally who might come for a one-time consult or might come once a year or once every few years for input. And so I similarly collaborate closely with outside neurologists and teams, and I'm careful with each situation to outline, okay, who's, and this is important, there should be a primary driver, especially from the neurology standpoint, and then other people can provide recommendations. So just setting up for each individual situation what makes most sense and what specialties are most prioritized. And so far we have a monthly clinic, and we try to coordinate, and recently with all the research, and thank you all for participating, we prioritized myself and my genetic counselor can see patients together, and we get all the research studies done sort of at the same time, and then we add on any other clinical visits that are needed. And part of that is that some of our teams, we have an aerodigestive team, which is already in itself multidisciplinary. It's a GI physician, a feeding team, a pulmonary physician, and a complex care pediatric. So they're already a fully built, incredible team that gives input that's really valuable for a lot of families. And so we don't want to break things that are working well, right? But we actually are at Children's building more and more disease-specific, true multidisciplinary programs, and have a single encounter system where you can come and get one check-in and one set of vitals. That's been kind of the burden of going to multiple programs. You feel like you're kind of repeating a little bit. So we're working in the next year, I think, to trial some of that. And I think it's always going to require some flexibility. So I hope that we can build more of that as opportunities allow for it, but still that's going to be sort of intermittent check-ins, and we need the flexibility, especially for kiddos who are super active. I'm actually working on systems for more urgent visits too, because we in neurology tend to be so overbooked that we don't have great systems for that. So building in more opportunity to follow closely for those kiddos who need close touch points as things get busy. So that's kind of a long-winded answer for
this kind of model also. We use a lot telemedicine to provide care, which is another piece that I forgot to mention. Telemedicine is also another important piece for the care of any person with a developmental epileptic encephalopathy.
Yeah, I think that's really helped to minimize the in-person aspect.
So it's really interesting for us to actually have this conversation, because most of our meetings are to discuss where we're at with our mutual research projects, but we're all trying to, I think, strategize and come up with better solutions for the clinical experience too. So just briefly about the St. Louis experience, our clinic, we started in 2015. It is within the Rett Spectrum Clinic. Every patient that comes to our clinic with CDKL5 sees me, and then our core within clinic team is PT, our AugCom team, which is OT and speech, that work together, and they will address OT as well as augmentative communication questions and seating. We also have technicians for orthotics and seating in the clinic, a research coordinator, and a genetic counselor who's available. And that's as well as our amazing nurse coordinator. And it's right, we sometimes forget that's the person who makes sure everything happens. So important. And then we have designated specialists within GI, pulmonary, orthopedics, even gynecology that are good choices for our patients if they need local care or consultation, and we coordinate if they come from further. Our region that we tend to cover is much of Illinois, all of Missouri, Kansas, some of Arkansas, etc., a little into Indiana, different part than LAFC's. So some of our patients are local, but some drive 4 hours or more to get to us, not because of traffic.
And in Philadelphia, it's a combination too. We do 1 half day a month where it's multidisciplinary, where we have a nurse practitioner, Erin, who's here, who kind of organizes everything. So she's really the boss. Genetic counselor, PT, OT, GI, and then we can coordinate scheduling with any other specialist that needs to happen on that day. But the biggest point here is, as everyone is saying, there's no one right way to do this. The biggest point is that all of us here understand the complexity of the care and all the care that you need, and we will, no matter how we have it organized, figure out how to get the right care to you at the right time. So that we're going to move on to actual talking about clinical issues. Judy,
Can I kind of chime in just briefly? I forgot to mention Dr. Hong is our other neurologist in the room who also runs the keto program at Children's, which is amazing. And Dr. Kim is our psychiatrist who's going to be doing the behavior talk this afternoon.
So something magical, as you know.
So maybe we will never get going.
Something magical, happens when you turn 18, unfortunately, at our hospitals. And sometimes there's a difference between 18 and 21. But it's important to note that some of us, our clinic is able to see all ages, but our hospital isn't necessarily able to see you as an inpatient after a certain age. They get really fussy about that. And so I think it's something for all of us to recognize. This isn't something that where we make the rules. We do our best with our clinics in the outpatient side, but on the inpatient side, it can sometimes be a challenge. But it's important for you and us to think about. I don't know if anybody else wanted to mention that.
And just a broader comment about that. So we all understand the challenge of transition from childhood to adulthood. It's a different world. No one's happy about it. But there are broader plans at stake. Lots of hospital systems, the Child Neurology Society, the American Epilepsy Society, are all trying to tackle this issue in a way to make it more seamless for everybody. But it is right now still a site-by-site challenge that we all have to face. But all right, now we're going to move on. Okay.
Yes. But by the way, there is a talk tomorrow afternoon about transitions if anybody's interested in coming to it. I'll be there. So even though the large part of what we intended to discuss with this panel this morning is actual clinical care, we did want to briefly share, because everybody up here was part of the ICCRN and have been part of many other research trials, sort of some of the key lessons we have learned from what and these are sort of pearls that we have all definitely know. Research is needed, but it turns out that even when it's not a high-risk study, it's just maybe full of lots of questionnaires that you feel like you've answered the same questions over and over, it's hard, especially when we have set time points. We learned a lot about that from the ICCRN study because, unfortunately, things come up, whether they're just practical family logistics or illness, that make it hard to participate. We found that even having home-based activities where you didn't necessarily need to travel was still asking a lot, and we really tried to think about that and not make it burdensome, but we learned that there are many challenges to this. So we thought this would be a really good topic to maybe hear a little bit from the panel, or if there are other comments from the audience or questions that you wanted to share about this topic. Anybody want to jump in over here? Maybe Scott?
Yeah, I mean, it's a difficult topic. We've actually spent many hours having discussions about how to try to be successful and rigorous with our data, meaning we get good quality data that's actually useful, but minimize the burden on all of you. We sometimes are successful at it. We sometimes are not. We work with our coordinators to try to meet you where you're at in terms of best ways of communicating with you, how to send you notifications, how to get you the surveys that have to be done. Is it easier to just do it when you're there in clinic, or is it easier to do it when you're at home? We try to be flexible about it, but also still try to make sure we're collecting the things that we can, and also be understanding. I mean, your kid gets sick, goes into the hospital, and like, you're not going to do something at that time, and that's fine. So I think that's just the overall philosophy of it, but we'd be happy to hear comments or feedback or anything about how that's actually been for those who have been participating in any of these trials or studies. Oh, yeah, you want to ask about seizure diaries?
After, but I was going to say, and one of the things that Tim mentioned in his talk, but it's still ongoing. You guys created a lot of data for us to analyze. Some of it for clinical trial readiness, and as Tim said at the end, we believe we are clinical trial ready. But there's also a lot of just clinical information in there about CDD from a large swath of people that we're still going to analyze, that we're still going to take a look at and try to understand patterns of medications and clinical features that showed up throughout the 3-year, 2-year journey that you were all on with this. So there's a lot we're going to learn about the disease and the condition that you all face that will still get out there to all of you, and lessons that we will all learn to improve care more broadly.
I would also make maybe one point, which sometimes you guys might be like, yeah, but what does all this do? What do you do with all this data? It directly informs things like, how do you design a clinical trial? What types of endpoints do you use, which determine the likelihood of success of that trial? The product that you're thinking about in a trial either works or doesn't. And that is what it is. We can't control that. The people who are developing those products can try to do the best they can. But if we don't measure it well and it works, but we don't show that it works, that's the biggest tragedy. And that's what we're really trying to avoid. We've published close to 30 papers over the last 6 years or so as a consortium related to these topics, which actually is quite a lot in the world that we live in and the types of work we're doing. Those papers are there in perpetuity. They're always available. They're always referenced. Other groups are using these as a model for how to do this for their own rare disease groups. And this has had a big ripple effect. And so what you guys have done and participated in is incredibly impactful, actually. Even if you guys maybe haven't felt that yet, it's had a big impact on the CDKL5 community scientifically, but also the broader rare disease communities.
I want to emphasize that even though the work seems to be burdensome at times, your contributions have allowed for the community to recognize CDKL5 deficiency disorder as its own disease. So we are not now, we may be lumped within the developmental epileptic encephalopathies, but the International League Against Epilepsy, which is the organization that sort of guides us in terms of diagnosis and treatments, now has said, yes, this is its own disease, and that have enormous repercussions because getting that degree of recognition, now we are teaching about the disease. So I hope that what we see in the next 5 years, and this is thank you to your contribution, because in 2014, we knew nothing. The first time that patients came to me with, okay, we have CDKL5 disease, learn about our disease, I have seen one case in my life. So now we are a group, and it's a recognizable group. And this is thanks to you. And I hope that we can get to the education to the level that we have multiple centers of excellence in each state in the United States and across the globe.
Helen, did you want to say something?
I want you to make sure that you guys know Helen and Jenny and Peter. While we know you in the clinic, you don't realize that somebody else knows you on the other side of the video. Did you guys want to stand up?
So I would be interested to hear from any of you who have done videos or who haven't done videos. What is particularly difficult for you, or do you find it easy once you get into it? That would help us understand whether we can make it easier for you.
Thank you, Helen. Are there other questions or comments in the audience about research?
Hold on, I think we've got a few, and I have some that were submitted on through the app. So let's start over here.
So first and foremost, it's funny how starstruckness changes now because I can't tell you what an honor it is to be in the room with all of you guys right now and everything that you've done for the community. So I just wanted to say thank you first and foremost. That being said, I personally am happy to answer a million questions. You guys keep sending the surveys, and we're here to provide all the information. And I understand you have to use the standard questionnaires, which is fine. And Dr. Raj is going to smile when I'm about to say. But my wish is at the end of all the surveys that you have us fill out, if you can say, if you could ask us which questions didn't make sense, which questions didn't you like, and which questions do you wish you could have answered differently and how, or which questions do you wish were asked, I think that information would be helpful for you all, even though it's outside of the standard questionnaires, because every time I fill those out, Dr. Raj hears about it.
Thank you. That's a really good point. I've had this discussion many times with my research coordinators because I agree there's a lot of room for interpretation with these questions, even though we try and think about it. But some of them were created by us, others are based on pre-existing, and so yeah. But I really agree with you on that point.
So I'll maybe just make one comment, which some of the measures that we've utilized over the last several years, we've actually developed ourselves. And as part of the development process, we did go through exactly what you described for a period of time. It was a limited period of time. It was not ongoing. And some of that is when you go to very large numbers of patients, even hundreds or 100 to 200 patients, it gets a little bit harder to sort of interpret some of those things and be able to continue to incorporate those comments. But we did do it early on to try to make sure that we were capturing what was meaningful and important to families with some of the measures. There's also some measures that are not designed for CDKL5 that you all have been answering over the last many years, and those may or may not feel quite as relevant in some of those ways, and we understand that also.
Scott, I can't wait to meet you in a little bit too. But my only comment to that is hopefully maybe AI could help with now like sorting through maybe the comments that you weren't able to use when you was doing that previously. But I just think, I know from my end, and I'm seeing a lot of shaking heads, that I think we wish we could give that kind of feedback at the end of taking the time of doing everything that you guys need us to do.
We appreciate that.
Are there any questions in the app, Karen?
So there are, but are we doing it by topic?
Yeah.
Okay.
Yeah. Okay. And
So
then, yes,
I've got like a sleep question, but I don't think we've
we'll
done
get
that
there.
yet. So,
We'll get there.
yeah.
We hope.
And a couple of others, but
Okay.
So this is a, hi, thank you very much for being here. This is a question about research, but if you guys want to maybe answer it, it's kind of a research/clinical question. And Dr. Marsh actually heard me about that yesterday. So I have a bit of an older daughter now, she's 8, and at the beginning of her life, I feel like I had a lot more energy for research and I was trying to do everything that I possibly could. And now, after so many years, I'm so grateful for you guys for sustaining your energy of doing all this, because I feel like I've gotten so much more exhausted than I was 8 years ago or 7 years ago, and so I'm trying to preserve some of my energy and doing what we need to do to stay stable at now. I feel like is that I don't have the answers. I don't know what to do next sometimes. I don't know how to try what medication, when, and in what way. And sometimes our neurologist, who is fantastic and such a team player, asks me because he's not, you know, first of all, he's not a CDKL5 expert, but also I don't know that we are, any of us, CDKL5 experts. I mean, we're all kind of moving along together, right? So I wonder if you guys can use any of the research data that you've already collected to make any kind of a semblance of a decision tree or something to help parents guide their lives at home day to day while they wait for, to the point of Dr. Marsh, you know, you fill out all these questionnaires and then you haven't seen the benefit maybe yet, like the big benefit that we're all waiting for. But a smaller benefit maybe could be in our day-to-day lives to give us a little more confidence that we're helping our kids and that we're making the right choices for them, because to me sometimes this responsibility feels like it takes my breath away and I just don't know, it's like heavy. So I wonder if you guys have thought about using the data in any of that kind of way, or if there's any way to use it.
Since you already talked to Eric about it, does he have the answer ready to go?
Okay. He said
Thanks.
to ask the day of the panel.
So as I already, yes, I said ask the panel, which is what I said. But No, yeah, as I already said, yes, we will. The plans are to start looking at, we've looked at the data for this idea of clinical trial readiness and doing all the analysis that has been towards each measure, how the measures interact, and how it could be used to get ready for a clinical trial. And there's a lot more detail in there that we could start to pull out for how will this help clinically for now to answer, is there a best medicine? Is there anything like that? And so, we meet monthly to talk about other projects, and these are the types of things that over the next little bit of time we will all be hopefully trying to tackle. And new technologies, asking Peter what the real answers are things that we're hopefully going to be getting to soon. And I don't know if anyone else has a comment.
Yeah, I think that's right. We've collected maybe not all the data we could collect, but we've collected a lot of data. We do have drug data. When did people start stuff? When did they come off of things? That's all rich for being able to start to look at exploring other things like that. Epilepsy in particular is a tough one, and I think all of us would say that what works in one family is not necessarily what works for another patient, and I don't know that we're going to come out with an answer that's quite as clean cut as we all would like it to be, but we have data there that we can see. Is there some way when we put it all together that we come up with some sort of signal that says, oh, you should do this, as opposed to what each of us have in our own experiences, which is with a subset of patients. And so the data is there to be able to do that.
I don't think it's set up as like a trial to answer any one particular treatment approach, but there is data there. And the other thing I would say is I think we can guess at what some of your hard decisions are and questions are, but if there's a way to learn from you and your community as to what are those hardest decisions that you're making with your home teams and how might we be able to help, that would be great.
I was going to make a comment about this a little bit earlier, but I think it's appropriate to jump on that now, that many of the most interesting research questions I've asked were questions that patients asked me during clinic. They said, well, I've noticed this. Do you see this with other patients as well? Is this a thing? And then we go and we figure out some data, we find out how to do it, and we're like, oh yeah, that is a thing, right? So we have a large data set. You guys have questions, you have experiences. We would love to hear from you. What do you want to know? We may not be able to answer all of those depending on what the data is there, but if we have the data to answer it, we'd love to be able to try to answer the questions that are important to you and feel unanswered.
Can I ask? Yeah. Hi, thank you so much for this interesting panel. Based on that you are talking about, the data that you have, for us as a parents, is there any timing, like talking about introducing new drugs? Any timing that we should take as reference as the one to wait to see if we have positive results or not? Because of course, when you introduce a new medication and it goes bad right away, you have the answer right there. But when it's not that obvious, and then you need to wait a few weeks, because I believe it was Relutrigine saying that after 4 months, not weeks, but months, you started to see the seizures decreasing. So based on all the research that you guys have, would you say there's a timing? And I understand each kid, it's different, but would you say that, hey, you need to be patient and wait for 2 months, 3 months, or whatever number, if there is any, to see whether a new drug is being positive for your kid or not?
So we haven't studied a lot of these things systematically. So what we will end up with is, if we were to write a paper, for instance, about what is your roadmap, what are the care guidelines, there's not enough data to put it into the certain sort of level of evidence. I think that what you will get at the moment, if we were to write this paper in the next week, it will be our opinions as to what we could do. And I think that the question is how useful is that? We could put a lot of caveats about everybody's a little bit different, but it is something that could be done. It's what was done there are care guidelines for Rett, but they do have a bit more base of literature behind them versus opinion. And I think that until we have to start somewhere, so it may be useful to just put our opinion out there. I don't know what everybody else thinks.
Well, I was going to say, as Scott was mentioning, right, we have this data we can start to look at. It's probably not enough, not done in a way that it will give definitive answers to these things. But what it might do most importantly is, what's the next question, right? Like, so hearing from you guys about what the next question is would be interesting, but the data will also potentially tell us, hey, we have a little signal here. It maybe looks this way. Could we do a trial? Could we do some sort of care implementation where we can answer some of these questions in a more definitive way and not just our opinions, though whatever Dr. Benke says, we all listen to anyway.
So, and maybe to just address your question, if you're a parent trying to decide, do I try another epilepsy drug out of the bucket, or do I think about a clinical trial for a new epilepsy drug? Or do I think about waiting until one of these new epilepsy drugs gets FDA approved? There's different gates, and with each of those gates, there's different amounts of information available. That really depends on the context of the individual patient. What's going on with them? How severe are the seizures at that moment? What else has been tried? And you need to work through that a little bit with your lone neurologist and epileptologist. But expressing, I would be willing to think about a clinical trial, helps to put that in their mind, to say, oh, well, are there other clinical trials that might be relevant for this individual? And some of those may not be specific to CDD. They may be for epilepsy as a whole. And in other cases, there may be trials that are on the horizon that we're going to hear more about through the meeting, gene therapies and such for CDD specifically. And those are not in the next few months. Those are still a little bit further away into the next year.
I think also just from a very practical standpoint, it really depends on the medication, how fast it is to titrate. Are you reaching good levels? If you're able to get levels in the blood, sometimes even then it does take some more time. So it takes more patience than a lot of us necessarily want to have when things are tough. And you know, can you do one thing at a time? Are there multiple moving pieces? So I'm not sure there's one answer to that question, except that it takes more patience than we like.
I think one of the things that I think that we have guidelines from epilepsy in general, the management of epilepsy in general, that we can extrapolate to CDKL5 deficiency disorder. And I think that I invite you all to work with your epileptologists on doing a plan that makes sense, because we know that the plan that doesn't make sense won't work. And I'll give you examples of that. When I start working with CDKL5, I hear from some parents, no, what worked for us is a very little dose of medication, but when they came, they are on 5 or 6 medications, all on their dose. And they're having daily seizures. And 5 or 6 medications on their dose will not control the seizures and will pack side effects. So that plan doesn't make sense, right? The other thing that I hear is that I want to keep that medication because it helped with that seizure when they were 2, but now they are 8. But we know from epilepsy that the seizures change along the life. It's the natural history for all epilepsies. When you are a baby, you have infantile spasm, then when you get older, you get Lennox-Gastaut. And we know that the guidelines for treat those are different. So it doesn't make sense to keep a drug for a seizure that is gone, because it may have been because the drug worked, but it's probably because the brain is developing. So you need to let go of those old ones to bring new ones, because we also know that if you add too many drugs, then we create disease. We worsen constipation, we worsen drooling, we worsen hypotonia, we increase sleepiness. You heard of all the drugs that we were talking about. These are newer. They all cause sleepiness, right? So if you start adding more and more drugs, it's not good. And Helen published a paper with a group of us, and she showed that the driver of poor quality of life in CDKL5 deficiency disorder is having more than 3 medications. And the areas that are affected are the areas of health. So more medication causes poorer health. That's what that data means. So these are the things that we need to keep in mind when we are picking and choosing and deciding to go for new treatments.
I was just going to add, sometimes it's not about new treatments, sometimes it's about new use of old treatments. So, for example, Heather, you're starting the keto trial, right, for DEE. So we know from all of the data that we've collected from you that perhaps some seizure types don't respond as well to medications that we thought that they should respond in a way. For example, spasms are not responding as well to steroids or to vigabatrin as we had hoped. And so coming up with new treatments, even if it's an old treatment but used in a new way, is something that we're also trying to find new ways to help mitigate seizures.
We don't know if there can be a preventive approach, but we have a small pilot trial looking at ketogenic diet for prevention of spasms in genetic epilepsies. So we will see.
So in my situation, not trying to talk about my daughter specifically, but we took her off all anti-seizure medications and we didn't notice any increase in seizures. We noticed a decrease in seizures, very small amount, but the seizures still persist. And I'm wondering, how do families decide about what medications to use when we've tried them all and they've all been ineffective to varying degrees? Some have been more effective than others, but in the end, ineffective. And how do we decide on which trial is the best trial, whether it's fenfluramine or ganaxolone or one of the other drugs? How do we make these decisions when the outcomes from all other medications that they've been on have not been effective?
So I just want to comment that thank you all. We didn't have to do the introduction to this slide because you've just hit all the points on there that we were going to raise.
I thought it was pertinent at the time.
Yes, it was perfect. Go ahead, guys. Anyone want to jump in on that first?
We're fortunate in the CDD community that we've had drug trials and have some evidence, and because of everything that you provide in our network, we're kind of learning from all the families and everything that's done previously. So like Heather, Dr. Olson, she did a publication that we're a part of looking at treatments for infantile spasms and CDD and what drugs might have helped. And, I'm not talking, but most of them didn't work. And keto had some signal, but, just from history and learning and some of the drug trials that are currently being done or drugs that got approved for CDD, at least we have some basis to go, which some rare diseases don't have. I definitely have CDD families who are on very minimal medications or none. And that's kind of a conversation that I have with them about safety and rescue medications and when do you reach for a drug if things are getting out of hand. And these kind of things are always discussed because every family is different and there's a degree in tolerability for seizures, and it's just a daily conversation about what each family's goal is. So I could totally understand if you feel like seizure medications aren't helping, what to do. Are there diet versus devices, and what can we offer to make your goals of care and your family happy? So, but everyone's different, and we try to learn from what has happened before.
Yeah, I would concur that, you're far from the first family with CDD that has said, like, these meds aren't doing anything, why am I on them? It's really tough epilepsy. Like, you all know this, you live this. We take care of lots of different types of epilepsies. This is, if not the hardest, it's one of the hardest types of epilepsy there is to take care of. My overall experience is that if you keep trying, you can get things a little bit better. Over time, trying carefully and systematically, but it's different with every patient what that lands on and what that regimen looks like. My one caution that I give in general when the question of being on no meds comes up is the risk of SUDEP. So outside of CDD, just in the epilepsy literature as a whole, there is some evidence that if you're not on any medications for seizures and you're an individual with epilepsy, the risk of SUDEP is higher. SUDEP is sudden unexplained death in epilepsy. It's the thing we're all most scared of. It's like SIDS, but with epilepsy, you come in the morning and someone's gone. And so we don't really know what that means in CDD specifically. There haven't been those types of studies, but in the general epilepsy population, there's some evidence that not being on any medications or being inconsistent with medications can increase the risk for SUDEP. So I counsel about that.
And we are looking into that, and we're going to talk more about that tomorrow, actually.
And I would just say, yes, this is hard. You are heard. We are here with you and happy to talk to individual neurologists and help think through. Ultimately, it's an individual situation, a risk-benefit ratio of any individual medication, whether it be approved and or what's known and unknown about experimental and what the risk tolerance is. And I would not say to each family in the room to go home and say these meds aren't doing anything, let's take them all off immediately, because that could be dangerous. But I have, in a couple of situations, had kids come completely off medications. Usually you go back on at some point later, Barry.
I have a question for all of you. How many of you have seen that when you're trying to get rid of one medication, the seizures get worse? When you are taking off a medication, you make a plan with your doctor to start weaning a medication, and seizures get worse. Only 2 hands, only 3 hands.
No, there's more.
4, 5. And who has seen that by reducing medication, seizures get better?
Equal number of hands.
Thank
equal
you.
number.
Yeah, we should look into that.
All right, we could stay on epilepsy forever, but we're going to move on now.
But if you would like to discuss epilepsy more, at 2:00, Dr. Hung and I will be talking about it. And so, yeah, no, it really, all of these are really complicated decisions. And that's, I think it was Dr. Olson who said, like one of my colleagues here said, you need a captain, and it really is a co-captain. Find one doctor who you really feel like you have a balanced, I'm sorry, I don't know your name, but it shouldn't be that we're putting the burden of the decision on you, but that you are heard. And sometimes I'll say, do you want me to tell you what I think you should do, or do you want me to just lay out your options? But it's always a risk benefit. There's always so many different things going on at one time. That being said, one of the other topics that is so important in clinical therapy is optimizing therapies, and I'm specifically referring to therapies to help with developmental improvement and physical health. So wrote down a few pearls that I think our group would agree on, which is it's so important to be upright and mobile as much as is possible. It's important for all of the reasons you could possibly think of: pulmonary health, bone health, just general engagement with your family and your community. Using augmentative communication or whatever form of communication best supports your child's ability to communicate, and recognizing the impact of cortical visual impairment, because if you aren't able to see as well, it makes it really hard to do certain things like augmentative communication if you're using eye gaze, or make progress with your gross motor skills. Those are some jumping off points, but if anybody from our panel wants to add things, or if there are questions specifically about therapy, we want to open up for discussion for that.
Anyone want to make any comments about how they use therapies or recommend therapies in clinic?
I would say one of the questions that I have in my mind from all of you, as many of you do intensive therapy programs, and I hear lots of positive benefits, but there's really no data on that. I don't know what others think.
And I find that the use of the communication device is all over the board, and I think that we should look into use it more, because there are kids that clearly can communicate, and we are just not giving them the chance. So work with the schools to make sure that they get means for communication.
Any questions?
And,
go ahead.
Oh, sorry. Yeah, I would say I completely concur with you, Heather. I think there is enormous potential out there for these really intensive PT, OT programs along the lines of NAPA therapy, etc. And we're actually starting to work together with a physical medicine specialist looking at therapy protocols and formally evaluating them for how successful and how long of a duration the success is for, because a huge problem with those programs is that they typically help, but a couple of months later the effect wears off.
And they're expensive.
The comment I was going to make around the CVI component was just that it's okay to be creative and work with your therapists and with the school to be creative. It's not a one-size-fits-all. Sometimes it's a device. Sometimes low-tech actually works great. Communication boards, things like that. Some people, despite CVI, can use eye gaze. Others are going to bat at something. So you have to kind of work to see what's going to be the best fit for an individual.
So I would like to add a comment. It's not a question. So I represent all the Spanish families here, 44 in total. And last year we did a very interesting project that lasted 1 year. about augmentative and alternative communications. So anyway, we contacted a company, and then every family that participated in this program could use for 4 months a communicator at home. And what I would like to encourage families to use it, because so many moms were very sure that that was not suitable for their kid because the kid was very affected, and you have no idea how many families were very positively surprised and could, for the first time after 19 years old in several cases, to talk to their kid. So yes, they can. Of course, it takes time and effort and energy because you have to teach them. You have to learn how to model that. But it was so incredibly positive to see moms that already, gave up on that, and now they have a chance. Yes, it's very expensive and everything, but if there's a chance to try, I really, really recommend that everyone just give their kid a chance, no matter how old they are or how affected they are. Talking about only visually, like we had a wider range of kids differently affected, and overall was very positive.
And there can be grant programs for that kind of thing if expensive is a barrier.
All right, so another question, go ahead.
When our daughter was in school, she had all therapies. She actually trialed a Toby, and we continue to use that at home. But when your child graduates from school, all therapies stop. And it is absolutely horrible.
That is a
Yes.
big problem that we have.
It's a huge problem.
That is correct.
Yes.
Yeah, remember, you can, often someone can prescribe a course of outpatient therapies, which will then be limited by your insurance and how many times they can go and what the goals of those therapies are. But you can each year continue to try to prescribe depending on insurance and things like that. Yeah, who's willing? Yeah, no, yep. It's a terrible situation. It really is.
There's an element that even before you get to what some people call the cliff, where you kind of age out of a lot of services in this country, thinking about when you still have those therapists, how can you integrate aspects of therapy into everyday life? How do you just encourage mobility where you can? How do you sort of do some of those things? Because in many ways, that's what you have after you age out of some of those services, is to try to maintain through life activities the best you can, and then potentially punctuate that with some targeted burst of therapy if you can get access to it.
Basically, if you have a caregiver that helps at your home or yourself, become the therapist.
Yeah.
Yes. Yeah.
Which isn't fair,
Area for
but is
advocacy.
part of reality. Yeah.
Advocacy.
All right, well, one more, and then we're going to move on to the next topic.
My question is related to gastrointestinal problems and epilepsy. If you could please go one by one, I would like to hear what do you think and what the data as well says. Is there a causation or a correlation between gastrointestinal problems and epilepsy?
Yes.
Yes.
I think everybody's nodding.
Yeah.
And actually, like if you, I don't know, 10 years ago when I started getting into seeing CDKL5 patients, there was like, oh, I see this whenever they're constipated, then they have more seizures, or etc. Families would say it, and everybody kind of went, yeah. But like it's all the time. Families are telling us it's not just for CDKL5; it's across lots of other developmental epilepsies as well. We see this sort of pattern. Do we understand it? No, not well at all. Is it true? Yes. Are you crazy? No. These things are true. You absolutely have a connection between what's going on in your gut and how that is being regulated, and occurrence of seizures and triggers and things like that. They sometimes are hard to figure out a little bit and maintain in a particular individual, but yes, we absolutely hear these things.
So you can see point one on this gastrointestinal slide. And just to note, right, for most of these things we're talking here, there's breakout sessions. We'll get into details with it. So hopefully you bring all your questions to each of those breakout sessions. But point one is important. It really is. And just to mechanism, right? We know the vagus nerve stimulator, some of your children might have, works by retroactively stimulating the vagus nerve. That also goes to your gut. And when you're constipated, it's altering that activity. Is that the connection? Maybe. As Dr. Demmer said, we don't really know, but there's some thoughts about how this could work.
And I would say constipation is certainly the big one, but also reflux motility concerns. These are very common in the community and also contribute to seizures when your children are in pain.
Yeah, I've got a question from the audience. This is Rick being a translator. Good luck. And I'm not sure which discipline this pertains to. But he says, I have a question regarding MERT therapy. Does that ring a bell? No? Nobody knows what that is?
MERT?
Yeah, capital M, little e, RT. Okay, Dr. Pastani knows. All right,
No,
so.
I'm trying to point to
Very bright light right behind your head.
That light is so bright. Thank you.
Sorry. I thought there was a light bulb over my head. I had an idea. Well, I'll ask the question, and if we can't answer, we can take it off. It says, I have a question regarding MERT therapy. Our daughter with CDKL5 underwent MERT therapy, and we observed meaningful improvements, particularly in her motor skills, object manipulation, and language development. Are any of you aware of other CDKL5 patients or families who have undergone MERT therapy, or are there any ongoing studies or documented experiences evaluating its effects in this population? I wonder if MERT is an acronym in Spanish that didn't translate into.
Well,
It's an intensive therapy.
Yeah, and I think the answer to that is this is the wonderful thing about community, and that online to all figure out who has done it, kind of get some information, come back to us as a group and say, what can we do to try to answer this more carefully?
So it looks like magnetic e-resonance therapy.
This came out in the popular literature, but not necessarily any peer-reviewed publications to say that it was safe or beneficial. And it wasn't clear that when you think about safety and beneficial and impact, some of these things are they're not, because they're not approved by insurance, you would be asked to pay for this out of pocket. And so it's not, I think that there is the potential to do harm to your pocketbook as well. Even though you want to do something, it may not always be safe. And so I think that it's just important to, what is really the evidence that's behind it? There is no evidence really that when I heard about this, I guess it was about 9 months ago, I couldn't find anything that said that it was really beneficial. And the answer to the question is no, nobody's doing any trials with it yet. And it's not really clear how it works or if it will work. And so we're still left guessing until there's more data.
There's a couple of questions that were submitted online. So one was about sleep. There was just, but do you want me to wait or do you want me to?
We're
Okay,
running out of time, so just go ahead
Yep.
and ask.
So, well, one is like about what medication combinations you found most effective for sleep disruption and any differences on sleep onset versus night waking. And then there's also one about what medication combinations you found most effective for sleep disruption and any differences on sleep onset versus night waking. And then what are the most important short-term and long-term benefits and risks that people sometimes underestimate? And I know some of this might be great for the physical medicine doctor who's giving a talk. What should we ask that maybe we don't know? And if it were your child, what information would you need to feel confident in a decision?
I would just say for scoliosis surgery, within CDD and outside of CDD, I've had many patients go through it. I would recommend getting probably multiple opinions because there are different techniques. Some surgeons will recommend waiting, others will say you should do it sooner based on what the scoliosis curvature is. There's not a right answer, but I would say finding a surgeon that you're comfortable with, who's done it plenty of times. Sometimes your neurologist recommends certain surgeons that they've dealt with over the years. But I would say probably get more than one opinion just so that you're comfortable with because it is a big surgery.
Right. Scoliosis surgery is scary, but sometimes when it's really needed, there's consequences to not choosing the surgery too, right? Like there could be a consequence to the surgery, but there are consequences when it's severe if you don't choose surgery. And I just think that's just for me.
And those consequences are pain, worsening lung disease because your spine is twisted, your lungs cannot move out the secretion, and also heart problems because the change in the anatomy. So those are things that need to be keep in mind when making the decision.
And even worsening GI issues too sometimes.
So from that perspective, my advice is to think about scoliosis and bone health early and know that it's an important part of the picture so that we can minimize long-term impacts.
I think we're standing between all of you and lunch, if I'm not mistaken. So we're probably going to get cut off here in just a minute to just like maybe do a teaser on the sleep component before we have more sleep sessions later. There are medications that can be helpful. So we talked a bunch about how like we do all these epilepsy meds and like, I don't know whether it's helping or not. It's sometimes the feeling. Sleep, we can help very often. In some cases, I feel I have more success helping with sleep than with seizures. So trazodone, clonidine, Neurontin, sometimes we do melatonin as well, but you may feel that doesn't carry through the night. So there are options. There are other options beyond that. I'm not going to say which one's best for every patient, and sometimes it takes a little bit of trial and sometimes a combination, but we can help with regulating sleep and making things better. Doesn't mean it's perfect sleep. It doesn't mean you're never waking up in the middle of the night, but things can be made better. So it's worth having those conversations.
And the sleep specialists are good partners to
Absolutely.
us. They're very helpful too.
We kind of skipped over behavior, so I just want to mention that Dr. Hong and Dr. Kim are going to have a talk this afternoon, and I'll mention a little bit about our EXCEED study where we looked at individuals with independent communication and motor skills, and we see a lot of behavior challenges in a good portion of that population. So we know that if the overall picture is less severe, at least in some ways, there's different challenges. We can help with those too.
Okay.
I'm just curious, and this is, as it's going on in my head, I feel like it sounds stupid, but is there I don't know who's doing the movement disorder, talk later or whatnot, but I'm just curious, like, is there a specific correlation between like movement disorder, seizures, like potential like surgeries, like in terms of the spine? I've got a personal, story with my son, but like, I feel like I'm crazy in my head for like things that have gone on with him, but like, I just don't think I can be this crazy. Like, there seems like there's a correlation between all of them that I can't figure out. And I guess that's just my main question. Like, if the movement disorder is high in him, like the seizures go away. And if the movement disorder is like cured, then the seizures come back, and it's like, I don't know what to treat and what, I don't know.
Yeah.
Is that your observation, that when the seizures are up, the movement go away, and when the seizures go away, the movement increase?
Yes, like the movement for in my case, the movement disorder appears when something else is like tragically wrong, like there is pain or something else, and we did find a very big problem with, there was an infection that my son caught in the hospital after surgery, so that I knew that something was very off and different, and the movement disorder stayed for a while, but while the movement disorder was active, the seizures were completely gone. They were non-existent whatsoever. And then as we tapered the movement disorder away and it got better, meaning we cured the infection and all of the other things got better also, the seizures gradually came back, but really lessened. Like they're not really back. I can't really explain it, but
I think you pinpoint really beautifully the huge overlap of movement disorder with all of these domains, right? Be it sleep, be it seizures, be it neurodevelopmental development, pain, discomfort, thanks God. Certainly medicines will play into that. Certain medicines used for seizures might influence and decrease your movement disorders as well, right? So it is an extremely complex territory there. That's not to say that they're not fundamentally linked at the get-go, and I think we need to look into this quite a bit. And you're welcome to give part of my movement disorders talk.
And you're not crazy.
I think we could have probably gone on for 3 hours because there is so much to talk about, but this really was meant to be an intro to, there's so much to talk about. And I think we could have put any one of us behind the microphone, picked one point from one of these slides and talked for an hour. But we just wanted to kind of share some of our thoughts. So you want to say anything?
Yeah, and we're here. We'll be around. Don't be shy of pulling somebody aside and asking questions. Obviously, we can't give direct medical advice without seeing your child, but to ask our opinions, to pick our brains, not our noses, of course, and would be feel free to pull us all aside.
They're really accessible. They wanna talk with you and learn from you. Thank you all so much. Can we give them a round of applause?